Okay, well, I'll go ahead and get started because we certainly want to give time to our wonderful speakers today, Lauren Moo and Kristen Dillon, who will be talking about utilizing VR and robotics in dementia. Again, my name is Bianca Frogner. I'm the chair of the webinar committee for the Award Network. I'm also part of the leadership team for the Award Network. And we're really excited to have our speakers here today, really excited to see how many of you are joining us today. As always, these webinars are recorded for future viewing. And so if you ever want to share this out with other colleagues or want to go back and see our other webinars, you can scan that QR code in the right-hand side and see those past recorded webinars, as well as see what our future webinar topics are. And we always welcome ideas from you all, where you can provide ideas via a link that's at the top of that webinar's page. And so all these ideas of webinars are really coming and inspired by ideas that you all share with us. So what's coming up in December is that we'll have Catherine Carroll Britt talk about exploring lifestyle factors of spirituality and religious activities for cognitive health in older adults with dementia. So that should be that should be very informative. And then in January, to kick off the new year, because the first Wednesday of the month is New Year's Day, we are moving it to be the second Wednesday of the month. And so that will be January 8th. And we want to share your research. We've done this 2 times in the past. So this is making it our third annual speed sharing activity, where we hope to select about 6 to 7 members, where we will hear from each of you for about 5 minutes about your latest research. It could be a work in progress or something that you recently completed. So there's a link there or a QR code. Either way, you can get to it. There will be an email blast asking for folks to provide their ideas. If you can get your ideas in by December 1st, by about midnight Pacific time, that would be great. And that would give us time to sort through the ideas and select speakers. Just a couple other things. I think this was mentioned last time too, but we have a workforce data compendium that's focused on direct care worker issues that's on our Award Network website. And there's been quite a bit of updated content. So I certainly want to encourage people to check those resources out. Lei Chen, who's a postdoctoral fellow with the Award Network, spent and really spearhead this effort. Many of you may be heading to the Gerontological Society of America conference that's being hosted here in Seattle next week. Some of you have probably already signed up for the Award Network's annual meeting, which is in the afternoon. And unfortunately, at this time, that has been filled. However, there's still space available for dinner. So if you are going to be at GSA in Seattle next Thursday, we will be having dinner that evening. And please email Laura Wagner at laura.wagner@ucsf.edu. And then we also will have a booth at the exhibit hall. So come and visit. I know I will be there. Joanne Spetz, the director of the Award Network, we will be spending some time at that booth. I think Laura Wagner may be there too. So please come on by and say hi. And I just want to thank our excellent webinar committee who's really brought many of these topics to life today. Megan Gately is the one who organized today's event, and she will be being the MC for the event today. And just I'll say quickly, thank you to our leadership committee, and thank you to NIA, who is the funder of this activity. So with that, I'll go ahead and turn it over to Megan, who will be leading this activity today. Thank you, Megan.
Thanks so much, Dr. Frogner. Thank you so much, everyone, for being here as well. We're excited, and I'm excited to introduce my 2 colleagues from the VA Bedford healthcare system. The first of whom is Dr. Lauren Moo, who is a cognitive behavioral neurologist at Massachusetts General Hospital and the site director for the Bedford VA Medical Center's division of the New England Geriatrics Research, Education, and Clinical Center, or the GREC. During her fellowship in cognitive neurology and neuropsychology, and her subsequent affiliation with the Cognitive Neuropsychology Laboratory at Harvard, Dr. Moo employed cognitive neuroscience techniques to investigate language and visual spatial processing. In the last decade, she has shifted to focus on research and clinical innovation related to dementia and the intersection of geriatrics and technology. Dr. Kristen Dillon is a licensed clinical psychologist and board-certified geropsychologist specializing in hospice, palliative care, and bereavement. She serves as a staff psychologist in hospice and palliative care at VA Bedford, providing psychotherapy, evidence based interventions, and grief support for veterans and their families. With expertise in aging, PTSD, existential concerns, and caregiving, Dr. Dillon aims to improve quality of life for older adults facing serious illness through her clinical work, research, and training endeavors. Again, I'm very excited to be introducing my two colleagues and to turn it over to Dr. Moo to get us started.
Thanks so much, Megan. Let me just share my screen. Hold on. Allowing me to share in the same way again. Hold on, because I have an embedded video that I hope to use. It may not let me share my sound. If that's true, we'll skip it. Okay. Can you see my screen now? Yes, thanks, Kristen, for nodding. People. So thank you for inviting us to talk again. As Megan said, we're going to be talking about using technology, sort of newer technology for dementia. And I'm going to be talking about robotics, a little study we did with robotics, and Kristen's going to be talking about some studies she's done with VR. And I just wanted to start out, though, by first, some disclosures. We don't really have any significant disclosures, and we do both work for the VA, but we're speaking not on behalf of the VA or the government. So the issue of technology and dementia more broadly is sort of a hot topic, as I'm sure many of you would appreciate. I just took this little screenshot of a PubMed search on the intersection of technology and dementia, and obviously the number of publications, if that's any indication of interest, has really ballooned in the last decade or so. But when we think about technology and dementia, we're really thinking not just about sort of the more high-tech stuff that really Kristen and I are going to be talking about today, but there's a lot of other ways that technology intersects with dementia that I just like to highlight because I think this is really what's useful currently for families. So really there's ways that technology and telehealth address different kinds of needs in dementia care. Some are focused on the person with dementia, the person with living with dementia, which I'll abbreviate with as PWD or PLWD in some of the subsequent slides. Those include things like reminders, sort of memory aids, assistance with tasks, enrichment activities, and monitoring activities. And then there's a bunch of things that I would say are sort of technologies that are really focused more on the caregiver of people with dementia. And sometimes that's to facilitate communication between the person with dementia and their caregiver, or communication between the caregiver and the family and clinicians, or educational opportunities for the caregiver. And I would also just point out that obviously the person with dementia and caregiver are a dyad. And so what helps one in general helps the other as well. So it's not totally clear cut that, this is just for the person with dementia or this is just for the caregiver, but some things really are, I kind of thinking about what's out there in this framework can be helpful. So how this impacts us as sort of clinicians and plan and policies related to the dementia workforce. I really think of this in terms of improving the lives of the person living with dementia in any way helps reduce caregiver burden and caregiver tasks. It can be helpful in assisting with various caregiving tasks. It can allow the person living with dementia to be independent and live independent, whether completely independent or say left home during the day alone, longer, and therefore obviate the need for paid caregiving or institutionalization. So, all right, so some things that are technology focused on really sort of reminders for people living with dementia are as simple as things like clocks, calendars, some automated pill dispensers, either with reminders, or some of them are more complicated, such as these sort of medication dispensers that have alarms and track whether or not people have taken their medications. These can be very helpful for people who have a hard time remembering to take their medications, and again, can make a huge difference as to whether or not somebody can be left alone during the day or can live on their own. And they're not high tech. There's other kinds of technology reminders, again, with sort of smartphone apps, with, again, medication reminders or calendar reminders, not just for medications, but for appointments or to walk the dog or whatever it is. Such things can be programmed by the person themselves, especially in early stages of, say, MCI, where they just need to program a reminder to set the alarm every night on the door or whatever. And in somewhat later stages, a caregiver or a clinician can help people program some of these reminders in. And again, this can make a huge difference, even though it's not very high tech. There's other kinds of assistance for people living with dementia, such as ways of simplifying various common tasks, such as making a phone call. If there are simplified interfaces for smartphones or for old school landline dialing phones, where there's just, say, a touch to dial with a photo and just the first name of somebody and maybe a limited menu, sort of, if you will, dumbing down smart devices. There's also, I'm a big fan, I've found that fewer of these exist currently, but for a while, many microwaves had a reheat button where you just push that button and it has a sort of steam sensor in it, and you don't have to think about how long you need to heat something up. It just heats it up until it's hot and then it turns itself off. So there's, again, sort of not that fancy tech that can really make a big difference in people being able to operate things on their own. There are various fancier apps that will have sort of task lists or actually has things where you can, I saw this app, I don't know how actually useful it is, but it lets you know if there's somebody in your vicinity who you know, who's in your thing, and it will remind you who that person is so that you are not as worried about interacting with people and forgetting their name, for example. Um, there's also all sorts of fairly passive technology that can be set up once, again, maybe not even by the person with dementia, but by family members that we are all fairly used to, but again, can be very helpful, like lights on motion sensors for the stairwell, so that you don't have to worry about somebody forgetting to turn on the lights before going up the stairs. Or say they're having financial, trouble keeping up with bills, setting up automatic bill pay. Again, these are technologies. Again, many of us use them already, but just thinking about more broadly ways in which technology can really help somebody who is especially in the earlier stages of MCI or early dementia, continue to operate independently. There's also technologies for enrichment and entertainment. And again, some of these are sort of taking what is incredibly complicated, such as television and various remote controls and streaming devices, or operating a music listening device that has become much more complicated than it used to be, and using a simplified version. So this little picture on here literally takes one CD, and there's a push, you just like lift that bar to turn on the music and put it back down to stop it. That can make the difference between that person being able to play their favorite set of songs when they want to and not. There's some sort of medium level tech entertainment and enrichment opportunities, such as very simplified games. This is sort of a gardening game. This is a sort of making pottery game app. There are, of course, these sort of higher tech brain training apps, which take a little more cognitive involvement, but can be entertaining for people. There's also companion robots and toys. People have probably heard of like Parvo, and then there's this sort of these very lifelike cats that if any of you have not had the opportunity to interact with one of these, they are quite impressive or uncanny, depending on your perspective. But for many people, these are meaningful companions and are better than having no companion. So we also have technology, again, not surprising, but I'm trying to put it all in one place for monitoring. These are things like motion sensors, letting you know that somebody has opened a door or left the house, that they've gotten up out of their chair. It doesn't have to be an alarm. I know there's some sort of controversy about things like bed alarms and chair alarms. It can just be a notifier. This can be helpful, especially if, say, a couple sleeps in different rooms, but somebody wants to know that their spouse with dementia has gotten out of bed. There's also all sorts of tracking technology that things like GPS built into smartwatches and trackers. There are smart GPS tracking devices that can be incorporated into shoes. There's, of course, we now, or lots of us are used to things like air tags that can be attached, dropped in somebody's backpack or pocket or purse. And there's the old school nanny cams for sort of, and, webcams and echo devices and things like that that can be put around somebody's apartment or home so that family can monitor them and feel better again about leaving them alone. And again, this can make all the difference about whether or not the family feels that they can continue to work or can be gone for the weekend or something. Okay, so that's a bunch of sort of fairly common, I'd say kind of low and medium tech options that are out there for helping people with dementia and their caregivers. But Dr. Dillon and I are going to talk about some somewhat higher tech, sort of newer things and some research that we've done about some higher tech approaches. And really, with these higher tech approaches, I think the question, often people's first reaction is, oh, well, people with dementia can barely operate. I was just talking about sort of dumbed down versions of common tech and how complicated our basic tech already is, right? Just operating your television and music playing device or smartphone. But really, I think the future is in having technology that has a really easy, intuitive user interface where the person with dementia is not the person who has to do any kind of customization or programming. And I think one of the questions is often, is this going to be acceptable to people with dementia and their families? What actually is feasible for this population? What are the potential impacts of any of these higher tech approaches? Do they actually have any impacts? And again, we're going to discuss two examples. I'm going to discuss this little robotics study we did, and Kristen's going to discuss a couple of VR studies. So, and I'm sorry, I keep switching between Dr. Dillon and Kristen, but that's the same person, as you can see on your screen. So, with funding from NIA for an SBIR that I helped to work on, and there's a citation in the bottom for this, we really were looking at, can a personal robot extend independence? And was thinking about adapting an existing robot for the ADRD population. And our question from my subpart of this study was sort of qualitatively, what functionality would people find useful in a robot? What format, and would they find it acceptable? And what are some potential challenges to implementing a robot in the homes of people with dementia? So this is a picture of the robot as it existed, and frankly still exists. I'm no longer involved with the company though, but we interviewed 6 clinicians with expertise in dementia care and management, 9 different family caregivers of people with dementia, and 6 people living with MCI or early stage dementia. And the way we did this is we interviewed these groups separately, mostly in individual interviews, except for the clinicians. We introduced the study by sharing a brief video about the current, at the time, the current capabilities and use cases for this remotely navigable social assistive robot. And the context that we shared, I don't have that exact video available, was an example of a student who was homebound due to medical reasons and was able to attend to virtually attend school by having the robot in the school that she could navigate from classroom to classroom, eat lunch with her classmates, raise her hand, talk, and so on, by having the robot as her sort of proxy in the school. And I have a video. I don't know. I'm trying to scan it, and I'm going to rely on you, Kristen, to tell me whether or not you can hear this. I had a hard time making the sound sharing click.
Newark 6, when a local junior high school student
Yes, we can.
home because of his medical condition, he was devastated, but a special robot is helping him attend class and even answer his teacher's questions just like his classmates.
Jennifer Action News reporter Sheldon Ingram takes us to Bessemer in Lawrence County to show us how this amazing technology works.
inside Mohawk Junior High School. And this pretty much looks like a typical classroom, but the person you're about to meet is not a typical student. Chris, come on over. This is Chris Kalaluka, and he is at home, but because of this robot, he is still here in the classroom. The robot is called Vigo. It's about 4 feet tall, slim, and agile. The person operating Vigo, Chris Kalaluka. The 7th grader suffers from spina bifida, but new technology puts him in the classroom with teachers and classmates.
Okay, so I'm gonna skip. You got an idea. This was not the exact video that we shared, but it was a very similar video. So just gave the participants a sense of what the robot could do at the time in a non-medical setting, and we really were asking about possible translation of a robot like that into the home of somebody with dementia, where they could the caregiver, the family caregiver, could potentially utilize the robot and maneuver the robot remotely from wherever the caregiver or potentially the clinician was. So this was semi-structured interviews. The question domains that we asked were about, again, of each of those different kinds of stakeholder groups, the perceived usefulness and ease of use of such a device, suggestions about sort of robot design and functionality and what they thought of the current design and functionality, what potential features and applications, literally apps and or other linked devices that they suggested might be incorporated and would be found useful, and just their kind of overall impression of the concept of having a remotely navigable robot within the homes of people with dementia. So I will also just say that our goal was to talk to people who were still living independently or were taking care of somebody who lived independently to the extent that they were at least alone most of the day, if not living completely on their own. So we were not talking about this for people who were already significantly reliant on a caregiver sort of 24/7. So when we asked about what they thought the potential greatest value of such a robot was, the results were dependent really on the group. So the people with dementia mostly identified that they thought it would be useful if the robot could get help for them in an emergency, such as if they fell down, and that it would be useful for doing video visits on the screen of the robot. The family caregivers were most excited about the idea of them being able to communicate with the person with dementia, such as to check in on them, to maybe the person with dementia was home alone, but the caregiver was at work, and they could maybe drop in and have lunch with them daily virtually and check and find where they were in the house if they wouldn't answer the call right away, and they could navigate the robot around to find the person. Dementia clinicians seem to be most interested in sort of using the robot to assess home safety, as with the people with dementia, could it do some kind of fall detection? But they were also excited about the prospect of this increasing the person with dementia's independence through a variety of possible uses. Regarding possible suggested future features and applications, again, this depended a little bit on who we asked. This is sort of a summary. The patients and family members were particularly excited about medication reminders and possibly even being linked up to something that could dispense medication. As I said in the last slide, the people were interested in emergency access. Patients were less excited than the caregivers and clinicians about communication, as you can see. Patients were also particularly interested in sort of reminders. So there was less interest, as you can see at the bottom of this, in doing social activities such as games or reading the news or using the screen of this device as sort of maybe a tablet or television replacement. So regarding concerns about the possibility of a device like this, both people with dementia and their family caregivers expressed some discomfort or lack of sophistication and kind of wariness about technology in general, and were worried that this was going to be too complicated for them and require that, that they were like, well, I'm not much of a computer person. Um, there was great interest in it having a user interface that was not currently part of what was already in the existing robot, where the device would respond to voice commands and where the person with dementia could just talk to the device to get it to do things. So that was insightful and new to us. And everyone kind of stressed the importance of there being a very easy interface, both within the home interacting with the robot itself, but also for the caregiver and any kind of navigation and programming that would be asked of them. Again, as we all know, a significant portion of family caregivers of people with dementia are spouses and therefore themselves often in the older age group and may not have as much experience with technology, apps and downloading and customizing them as our middle age and younger cohorts do. Clinicians and family caregivers all expressed concern about sort of privacy. Again, this is potentially a video portal into somebody's home. So making sure that it was very limited as to who could sort of drop in virtually, and whether or not they could drop in virtually versus needed to answer a call manually or with a voice command. Security features, are their data generated? Where would the data live? How secure is the connection? And again, I think related to the privacy, sort of some dignity issues. Like if the robot could be navigated by the family caregiver all over the home, might they wander in while they were bathing or using the bathroom or dressing or doing some other private activity? So putting some breaks and guidelines on that. So I'd say sort of other than that, some additional lessons learned, and this is a citation on the bottom to another paper that we had, is that highlighting what I just said. So what people thought really did depend on these different stakeholder groups. So I think it was important that we interviewed people, from clinicians and family members and people living with dementia themselves, that they had different interests and different foci. And what was interesting is that the people with dementia themselves, they seem to have feedback that was largely not related to the dementia or cognition itself. They seem to lack some insight into their own cognitive challenges and the future likely decline in their cognition and abilities and judgment. So that's the citation there on the bottom right. So I think in terms of I know that this award network has an interest in sort of dementia workforce. So I'd say that in terms of implications for workforce, I do think that these sort of technology enabled reminders, medication management, communication tools that many of our interviewees highlighted have the potential to allow people living with dementia to live alone or be left alone longer than they would otherwise, and allow family members to keep people living at home longer than they would otherwise. So I'm going to hand this off to Dr. Dillon.
Thank you, Dr. Moo. That was fascinating to hear about robotics and the pilot study that you all did. So I'm here to talk about virtual reality, which was a program that we implemented for veterans at end of life who are enrolled in our hospice and palliative care program here at VA Bedford. So I'll be talking about this use of VR as well as one for outpatient. And so in terms of virtual reality for hospice, what we have research has shown is that it is a safe and effective adjunctive care option that could have multiple clinical applications. And so for the purposes of our study, we are interested in determining whether implementing VR with veterans on an inpatient hospice unit and palliative care unit was possible. So to begin with, we wondered kind of what barriers and facilitators existed with implementation and how overall VR would be received by veterans enrolled in hospice and palliative care. So implementation is always tricky, I'm sure, as you all know. But what we started was a framework of the 4M's geriatrics, so mentation, mobility, medications, and matters most, with really a focus on matters most as well as medications. And I'll speak about that a little bit. So it was, to begin with, kind of figuring out what would work best for our population on an inpatient hospice unit. So this was thinking and considering hardware, what kind of virtual reality device are we using, the software we're using as well, talking to other facilities to hear about their successes and challenges in implementation of VR, of course, financing, and then creating policies and procedures because this was something very new to our VA. So our project development began in 2021, but unfortunately we weren't able to start collecting data until 2023, mostly because of all the aforementioned things, especially around infection control on an inpatient unit. So in terms of our participants, they were veterans enrolled in hospice and palliative care within our VA facility. So as I just mentioned, why the delay? Why that 2 years? So financing was a big piece, not only for the VR headset, but for infection control as well, that there are standards of care and best practices around infection control. And of course, those things come at a cost. So we were able to first obtain our virtual reality headset, and then one of the delays was trying to find funding also to buy a infection control device, which we ended up using something called a clean box, which is a UV light box that really kind of kills everything to make sure that our veterans are safe between use when we're moving from room to room and just having various people engage in this. Of course, policy creation always if you don't mind going back, policy creation also takes some time too. Thank you. So our methods. We ended up choosing a headset that was very passive. And what I mean by that is that you may have come across certain virtual reality devices. Oftentimes people are thinking about the Oculus or the Meta, as it's known now, that has hand controls and really is a very active experience. But what we know about our veterans enrolled in hospice is that many are bedbound, really kind of acutely facing their end of life. And for our palliative care veterans as well, that depending on the level of their illness or disease progression, that these folks just would not be able to necessarily engage as well with kind of an active experience with use of hand controls. And you can consider different presentations and how challenging that could be. And so we ended up going with two Pico headsets, which are, again, the hardware, and then two different software companies. So we started with the Soothe VR and then moved to the Penumbra. And what we really liked about the Pico was that it was something that we could set up ourselves, and we didn't even have to necessarily put it on our head to make sure that it was infection control, whereas we utilized, and then put it on the veterans. And so they could just sit and engage in VR without having to do anything other than be a passive participant. We also looked at mood, anxiety, pain, pre and post intervention. We asked about, if they recommended this, if they would recommend it to others, and quality of life post-intervention. We gathered a lot of narrative data, which, as Megan knows, was very, very rich. And this included not only clinical observations, but veteran comments throughout. And so we would just be taking notes about what they were doing. Were they looking around? What were they saying? And we also tracked PRN usage of medications 24 hours pre and post intervention. So we first piloted this on our hospice unit, then we expanded it to our palliative care veterans in our general nursing home, and now have moved it into the dementia specialty care units as well, which is really exciting. So in terms of the results, veterans really presented with a variety of different ages, disease processes, and mentation. 25 veterans enrolled in this project, and there were 65 interventions completed with virtual reality. So as you can see, the average age was 82, it was 96% male, again, veterans living on an inpatient hospice unit. But what was exciting is that we had actually almost half of participants had a diagnosis of dementia. And so we didn't necessarily go into this project thinking this is going to be a kind of dementia-focused intervention, but just as a result of our population, half of them tended to have a diagnosis of dementia or major neurocognitive disorder, and again across the spectrum. And so some maybe more mild and some more severe advanced. What we also found was that some of the veterans that did have dementia or cognitive impairment, and especially with communication difficulties, when there was a family member there to help facilitate and especially engage the veterans in reminiscence or kind of given that they know their loved one best, that it really helped facilitate the intervention and make it that much more successful. Also, 36% of people that utilized VR had visual impairment, and that ranged from kind of wearing glasses to more advanced visual impairment as well. And sometimes the glasses could be tricky, but for the most part, they were able to wear their glasses with the with the VR headset. And then 80% had a psychiatric comorbidity. So this is our VR use information. And so you can see for 92% of the veterans with which we did this intervention, it was their first experience. For others, that other 8%, if they were still with us, we would continue to go back on a weekly basis and offer. In terms of length of use, usually the VR experiences range from about 2 minutes to, usually about 16 minutes, depending on what they choose. And the average length of use was 7.5 minutes. 32% reported some difficulty using this set, and that was usually around adjustments that we had to kind of make sure that it was in their visual field and not blurry, and so they would kind of be talking to us. And so as you can see that little note at the bottom, 0% said they had side effects, which is wonderful. And then for the VR Soothe, it had different themes, and so escape, relax, and guided. And so you can see that a majority of veterans would choose experiences that were in that relaxed category. The relaxed category included travel. And so it makes a lot of sense. A lot of the veterans wanted to either utilize this for reminiscence purposes, to go back to a place that they'd been in the past, or for a new kind of bucket list experience. And so they really tended to go with the travel experiences, which fell into the relaxed category. 91% said that they enjoyed it, and 90% said they would use it again. 82% of veterans said that it improved their day. And so when we're thinking about hospice, there's nothing better than seeing something like that in real time, that these folks were saying, my day is improved because of the use of VR, which is absolutely wonderful. So we also looked at well-being, as I mentioned, so anxiety, mood, pain, and boredom. And what we found was that the intervention, really most people experience less anxiety after engaging in VR. So we asked about their anxiety prior to doing the VR intervention and post, as well as mood and pain and boredom. And so you can also see that their moods improved. We did not see a change in pain, and so that really did not change. And we did see that boredom was lower. Similarly, with PRN usage, we didn't see any changes in medication and pain management use between 24 hours pre-intervention and post. And so they were using about the same pain management techniques, which again, given a hospice population, makes sense as well. So this was so successful on an inpatient scale that we opted to expand it to outpatient, again, utilizing the 4Ms framework, and we were awarded a GREC Clinical Innovation Award to expand this to our outpatient mental health program. So for this study, we looked at veterans 65 or older who are engaged with mental health treatment currently at our VA outpatient mental health clinic. Really focused on that, what matters most in terms of the 4Ms framework. And for this study, we actually got that more active VR devices. So we're using the MetaQuests, which are formerly known as the Oculuses, and focusing on the use of YouTube VR. So unfortunately, there's always delays in implementation. And the problem here was that our VA network and firewall really caused a ton of issues with connecting to the programs and internet for our veterans. And so we had to work with a biomedical engineer to help us, and kind of joked with him, did you ever think that this is what you would be doing as part of your job, trying to get VR connected to the Wi-Fi network? But it was working really well. If it's not working for some reason, we do connect to a hotspot, which unfortunately sometimes can cause some buffering issues or blurriness in the visual field. So that can be frustrating for folks. But similarly to our other project, we measured mood, anxiety, pain, boredom, pre and post intervention, as well as that question kind of related to quality of life if it improved that person's day. The other challenge for this is recruiting veterans. And so we had some criteria in terms of they currently had to be engaged in mental health treatment on an outpatient basis, and of course, age restrictions. And so it's been more challenging to recruit veterans for this as well. So currently we have 3 veterans enrolled. This is a very new project, completing 11 VR interventions. So comparatively to the VR headsets that we're using inpatient, again, this is using hand controls, having to connect to the internet. And so I have found that it is much more challenging for folks, especially if they have a neurodegenerative disorder, and so or functional impairment. And so did have a veteran who had Parkinson's who really just had a ton of issue with the hand controls due to tremors and such, and would get very, very frustrated. And so what we would do in that situation is after he would choose and set up what he would like, then I would take the controls for him and put them down so he wasn't mistakenly clicking on other things or exiting out of the experience that he had chosen. Again, as I mentioned, sometimes with the connectivity, it could get blurry. And then the nice part about the Oculuses is that you can, or the MetaQuests, excuse me, that you can cast to a phone. And so I can see what the person is seeing. However, it wasn't always consistent. There were times that I was able to cast and walk them through, okay, click here, go, this is the search function. And other times I was kind of going in blind, having them trying to walk me through what they're seeing on the screen. So dissimilar to the other headsets where I could set it up and put it on the person. Unfortunately, the Quest is not that way. I can't set it up on my own head and then put it on someone else. But in spite of the challenges, the veterans really reported positive experiences with improvement in mood and anxiety. So similar to what we were seeing on the inpatient side of things. And one little narrative quote was, the elation from this intervention lasts 1.1 to 1.5 hours after. And so again, really seeing the benefit real time, and even this veteran kind of saying for a period of time thereafter. So I know, again, as Dr. Moo said, we're kind of also considering workforce. So what we have found in terms of workforce considerations is for the inpatient side of things, really ideally having 2 staff available to offer the intervention is really helpful. And so this can also allow for, if there's 2 people in the room, that one person is troubleshooting and kind of helping manage, setting everything up, getting things going, while the other can kind of be observing and taking notes. Because again, there could potentially be side effects that people are experiencing. And so we don't want somebody that's trying to observe or take notes to kind of miss anything as well. And then, of course, the other piece is that there's better efficiency and easier cleaning between participants. So one person could be running to the clean box to make sure that we're following our infection control policies, while the other's going to the next person to see if they'd be interested in doing VR. We currently are able to offer VR 3 times a week on our unit, which is really wonderful. And so we have myself, the psychology trainees, and we also partner with Rec Therapy as well, who offer this. And so we go multiple times a week, just recognizing, again, with our population, that people are not always going to be in a place to participate. They may be sleeping, they may have just received medications, they may be visiting with family, and so we wanted to offer this as much as possible. And so it's offered twice a week on our hospice unit, once a week on the nursing home side of things, and then once a week on the dementia specialty care unit, which is lovely. And also, if we had more staff, we would hope to offer it way more. Making sure that people have a lot of time to clean headsets pre and post intervention and set up programs. That's really important. So even when we're set aside an hour for VR intervention, that we're probably only able to see maybe 2 people, because the interventions can be a few minutes to 20 minutes. And then we're also in between and prior to cleaning and making sure that we're checking in on folks afterwards to ensure that they're not having any side effects or any potential sequela from the intervention. We also want to have staff available for pre-screening to assess for any contraindications. And so the contraindications are any sort of cardiac implant, so pacemaker defibrillators, as well as just vertigo, dizziness. We have found anecdotally, and I think I actually speak to this in the next slide, so I'll stop there. But in terms of for veterans with dementia, or maybe that don't have capacity and healthcare proxies been activated, also needing time to reach out to healthcare proxies or family members that are having decision-making capability, to talk to them about the VR intervention, what we've seen, the benefits and risks of doing so, and obtain consent. And then, of course, we've had to adapt measures based on people's abilities to communicate. And so we have verbal scales in terms of pain and mood and anxiety, but we also have, visual scales that people can utilize as well. And then, of course, if you are using the MetaQuest, this could be a VA thing, but having some sort of tech staff or IT staff available to help troubleshoot can be really, really helpful. I actually had to contact somebody the other day because they changed something with our Wi-Fi. It's not working again. And I said, can you come back and take a look? And he was more than willing. So that's really nice to have as well. So in terms of our discussion, just to suggest that our data and what we know with research says that these are feasible and acceptable in terms of the use of VR in hospice and palliative care, as well as outpatient settings, and for folks with cognitive impairment. Really having a very flexible and adaptable approach is important, as well as kind of individualized for each person. And that can really help facilitate engagement with, across the presentations that we're seeing. I've found anecdotally and kind of based on this study that really those passive experiences where we can set things up and just put it on the person where they're not having to utilize hand controls is much more appropriate than navigating the MetaQuest and those more kind of active experiences, especially for folks that have functional decline or cognitive impairment. Although recognizing with our more passive headsets, because they're pre-programmed with a certain amount of choices in terms of experiences, that they're not, can't kind of pick and choose everything that they would want to do. Whereas with the MetaQuest, it's kind of whatever their preferences. I'd like to travel to the Alps today. And so they really can be more deliberate and have a lot more choice with those programs. We recommend that people try a short program to begin to determine their ability to tolerate VR, checking in with them after a couple minutes if they're having any dizziness, nausea, what's it like for them to have the headset on, and just making sure that they're feeling okay with it. We did see improvements in mood, anxiety, and quality of life. What I was going to mention in the last slide, that there could be some contraindications beyond kind of the cardiac implant and vertigo and such. For folks that have severe cognitive impairment, active psychosis, or who are experiencing kind of acute delirium. And so, of course, we're not wanting to confuse folks more, and especially for what we've seen for the psychosis, when we've utilized it with some people, not all, that there can be some reality testing concerns and that they're feeling like it's almost too real. And then for the severe cognitive impairment or delirium, that it just can cause changes in mentation and more confusion. So again, it's also about knowing the person really well and monitoring and making sure kind of what's happening real time. And then, of course, the considerations for staffing, given the needs of participants in the settings in which this is being implemented. So for Dr. Mu and I, our overall takeaways are the use of VR and robotics and older adults and for cognitive impaired populations is feasible across a variety of settings. And adaptations are absolutely necessary depending on the cognitive status for the person and if you're working with the participant versus the family or clinician and what everybody's goals are. So I would love to answer any questions or if you have any comments, please.
Stop sharing.
Thank you so much, both of you. I was monitoring, so we have, in case people aren't aware, the Q&A is the best feature for entering in any questions or comments. So far, we had a comment earlier during your presentation, Lauren, about someone mentioned that their cousin has a similar robot for helping people who are unable to attend concerts or plays to get that experience, and that's pretty neat.
Maybe could I jump in and ask a question? This is really fascinating, and I can't easily enter into the Q&A, so I just unmute myself. So both of these presentations provide a lot of great context about the emerging technologies that are coming, and thank you for touching on the role of the clinicians in all of this. And given that there's so many new technologies kind of emerging, and many of the people here in the network are probably thinking about how to prepare the health workforce. Are there some like broad takeaways of things that you're realizing that clinicians should be prepared or educated about to get them ready for these new technologies? Because every technology clearly needs a little bit of, training here and there for that particular technology. But are there like some higher level things that you would love to see, like new graduates coming out with certain skills, or are there opportunities in continuing education that you see as needed to prioritize to help clinicians prepare for this? Because I can certainly see a discomfort that might come along, especially generationally among clinicians who are out there who may not be comfortable with technologies themselves, but even newer graduates too. They may not know all the things that are available because their curriculum doesn't provide it. So just love get your take on
I have
that.
a few quick thoughts. Thanks, Bianca. I'm not sure if this exactly gets at it, but one would be, I think there's this is like a very hot topic in terms of tech development, and that there's lots of things that have been offered, and I would say are not well thought through. And so I have patients come to me asking me about different things, and I usually don't know what they are, so I have to say I'll look into it. But often they're not they don't good, real data the way, Dr. Dillon does on and any kind of efficacy. So I guess I'm saying some of it feels a little predatory to me. And so I think that's something important for clinicians to know, to be the sane voice of saying, you know, this may not, they may just be looking to sell you something. And it is hard to keep up with all of it. That's why I sort of presented some of those lower tech common things, which people really do find useful. It doesn't have to be high tech, despite, Kristen and I are interested in some of this high tech stuff, but a lot of the good stuff is not super high tech. So I think that's one of the things I would say. And I think the other thing is that both for these and some of those sort of low and medium tech things and things, a lot of the stuff I've done, a lot of it with Dr. Gately has to do with like video visits, which is obviously not the topic today. But I think our lessons learned from some of that is that it does take flexibility on the side of the clinician and troubleshooting. And, Dr. Dillon described a lot of that. This is sort of the adaptations that have to be made are not just on the part of the tech developers or the families and the end users, but really on our side, if we're helping people with this, you don't need to be a tech expert. You can call on, IT if you need it, but it's not one size fits all, and you have to probably be a little willing to jump in and try and do some troubleshooting.
And I think, thank you, Dr. Mu. And I think just to add to that, so yes, flexibility, adaptability, and a willingness to try. I think we went through this, especially to implement, and we hit like so many barriers and had so many challenges. And I joke all the time that by the time we actually implemented, like the technology was completely out of date at that point. But really just a willingness to kind of think outside the box and recognizing that some of these technological advances can be really beneficial. Dr. Moo's point is very valid that some of them are a little bit more predatory, but for others that there's a lot of research and anecdotes to say that like this is beneficial, to be willing to actually try.
And it looks like we do have a question for Dr. Dillon. This is from our colleague Brent Schell. Could you elaborate on the barriers with enrollment for the outpatient study? Are they mostly related to the complexity of the VR device or privacy concerns?
So it's a little bit of just enrollment generally, like trying to get the right fit because of our criteria and the folks with whom we're trying to enroll in the program. So that's a part of it. Privacy isn't as much of a barrier in terms of oftentimes the veterans actually would like their caregivers there to participate, and it's really, especially if I can get the casting to work, it's fun for the family to see what the veteran is seeing as well. And so privacy hasn't been as much as an issue, but really it's like an adjunct intervention to what they're, for instance, if they're in psychotherapy or meeting with a psychiatrist for depression, that we can be utilizing this for not only what matters to them, but behavioral activation. And so it's more just about finding the right fits for for this project, as well as people that can utilize this device because of the hand controls and such. And so when we talked about being adaptive, there's times where I'm telling the veterans telling me where to point and I'm using the hand controls and such too. So
thank you. And Brent says thank you as well. And then someone has a comment, just very informative. Thank you. Love that you bring up such great questions for the group, and that hope that you keep studying this bright and growing field. So thank you very much for that.
I think we've come to the end of our webinar hour, and thank you so much again. And I realize my video seems like it's frozen, but it seems like you can hear me. So apologies that it's not quite syncing up here, but it's so fantastic to get this perspective on technologies and how they might help patients living with dementia in a way that we haven't quite heard yet in our webinar series. So thank you for bringing these topics to our group. And thank you to everyone for attending today. And again, sorry for my video just being frozen. That's really not a flattering picture of myself. But I hope you all have a wonderful rest of your day. And thank you to our speakers, Dr. Dillon and Dr. Moo, for being here, and Dr. Gately for organizing today. Thank you. Have a great day.
thank you all.
All right. Bye-bye.